it was of use to you. So with this small introduction, I want to hand over this today's session, which is just 3 minutes to start. Dr. Chatterjee, Dr. Nilanjan, who is here? Hello.
Chatterjee is joining, sir.
And Dr. Nilanjan Mitro? Nirmallo, Dr. Nilanjan Mitro?
Sir, he was joining. Although Dr. Jana has been joined.
Has joined. Dr. Jana has joined. Okay. So I like to have some feedback from the students. How was the class going on for the last few weeks? Some of you should come up with suggestions so that we can improve our session as per the need of the students. Mukesh Jaiswal, you are from which place?
Good morning, sir.
Good morning.
IGMS
Patna. So what is your impression about the class and what is your suggestion to improve this class?
Okay, no? The class is very good, sir. It meets the requirement of science final year. It is very helpful for us for
Thank
the
you.
exam going.
Okay. Dr. Shandip Manna, you are from which place?
Sir, Fortis.
Fortis Hospital.
Yes.
So how it is helping you?
Sir, it has been helping in just picking out the important topics, picking out the important places among the vast syllabus, and it has been also helping in the revision before the exams.
Now, do you want any improvement in our presentation pattern or participation pattern? Do you have any suggestion about it?
Sir, not right now, sir. It has been going very good.
Okay. Anybody else who wants to contribute with suggestions?
Tell me how good morning, young friends. Good morning, Ranjan. So tell me how is this course being organized at the right time for your exams, or you would want some continuing effort throughout the year, or something specific for the second year or first year? These are things which the secretary and I have been discussing for some time, and some feedback would be appreciated.
I think, sir, it would have been better if it had been organized a little bit earlier, because we are having exams in June. So maybe 1 month before the.
No. His question is, should we continue this effort once in a month throughout the year? Or apart from this intense course of two months, throughout the year, should this kind of activities where second year, first year can also join, and the syllabus can be revised from the basic to the practical end of the course? What is your suggestion?
That would be better, because in fact, while reading along all these years, we have wasted quite some time in reading useless things or unimportant without understanding. So these type of classes would have helped in that places.
Okay, we have to keep it in mind. By this time, apart from Otonu, anyone, Nilanjan, Udoyada, anyone has joined? Then Otonu,
Yes,
are you here?
Yes, sir.
Yeah,
I'm here.
Otonu, you please start the class. It is 10 o'clock. We'll have to start the class, call the students and start the session.
Yes, sir, good morning.
Yeah.
Hello. Hello.
Hello. Hello.
Hello.
Yes. Oh, Uday Chatterjee sir has come. He has joined. So Udayada, I have requested Otonu to start the class. You be in coordination with him.
Yes, yes.
Okay. Thank you.
Ranjan sir, good morning.
Good morning. Good morning. How are you?
I'm fine, sir.
Jamal. Okay. How it is going, Jamal? These classes and all. What is your impression?
Very nice, sir. I think so. This should be useful for the students. Very useful to the students.
Very useful to this.
Conduct is
Let's-
good.
Yeah.
Conduct
Let's
is
hope
very good.
in the next year we can extend the period in little more detail for where the second year students can also join, so that the discussion will be much more effective from the beginning. Let's hope so. Thank you. So let's start.
Good morning, all of my
Which is-
teachers as well as students. Who will be the facing the question today?
Sir, me, Dr. Jitendra Gawal, sir.
Okay, and
We have
sir, for
we have scheduled two students side by side, first three cases. Otonu, see the schedule?
Jitendra and Sumantro.
this.
Where is Sumantro?
Yes, sir.
Okay, we started our first case here. 7-year boy presented with a left flank pain with recurrent episode at 2019 as well as 2022, which is dull lacking, non-radiating, and without any other urinary symptom. So, how will you proceed this patient?
Sir, I would take further history from this patient.
Yeah. What will be the further history you want to know?
Sir,
uh,
sir, whether the pain, flank pain was associated with any hematuria or graveluria or fever or any other associated symptom or not. Whether associated with
Associated vomiting, sir.
Yeah.
Past history of fever with pain associated, sir, and history of
further history, I would like to
growth, history
Any-
of growth of the patient, sir.
So patient had no history of fever, no nausea, vomiting or constipation, no other urological symptom without any other comorbid illness. Now, what will be your next step?
Sir, we will like to general and physical examination of the patient, and sir, growth of the patient, and any stunted growth if is there.
So what will you look in examination?
Sir, for abdominal contours, sir, any swelling.
First divided into two. First one is on general survey.
General
What
survey.
will be the important finding in general survey?
Sir, I would want to look for features of pedal or peripheral edema,
Okay.
anemia.
Okay.
Other than that, significant findings, any lymph node swelling, any swelling in the body.
You
And-
both of you tell that you will show for the growth stunting. So what is the important parameter? How will you know the patient has a stunted growth?
Sir, patient's height, sir,
Yeah.
and growth of height
Height
to the
and weight.
age, same age group. Yes, sir. According to age group, sir.
Yeah.
And yes, sir.
And on local examination,
local
Local
examination.
exam.
Jitendra.
Sir, local, sir. Sir, for local examination, sir, I will say, sir, any swelling, abdominal contour, sir, if any swelling present there, sir, and bladder palpable or not, sir, and sir, sir, if any phimosis or not, 7-year-old patients, sir, so to look for phimosis and to look look for, sir, general genital examination and also.
So in the urological examination, examination of back from the lumbar region is also important.
So I would
Yes.
like to
Yes, sir.
elicit whether there is any renal angle tenderness, any renal lump palpable or not.
Yes.
And after that, proceeding with lower abdomen and external genitalia. Lower abdomen, I will see for bladder palpable or not. External genitalia, I shall start with meatus, whether there is phimosis or not. Location of the meatus, orifice, the diameter of the meatus, whether it's normal or not. Followed by normal findings like whether the bilateral testes are extended or not, whether there is associated finding of any cuff impulse or cuff impulse from that. And yes, and I would also like to see the lower back for any suggestive features of
Suggestive features of
uh, um,
Spinal deformity,
whether
sir.
there is any spot of the genital nevus or not, tuft of hair or not, or
That-
basically we
Dimple,
are looking for whether they need features of meningomyelocele or not. Okay,
yes,
because it is associated with the lower unit tract symptoms
yes, sir.
and also other congenital abnormalities. So
yes.
here is the examination finding. Patient has on the general survey the normal growth and abdominal examination, the no sign significant finding is there. So how will you proceed this patient? So what is your provisional diagnosis for this patient?
Sir, in this age group, I would consider urinary tract infections, hydronephroses due to distal obstructions as my preliminary diagnosis.
So distal obstruction means
Distal obstruction can be more commonly due to ureteropelvic junction obstruction and less commonly in this group due to stone disease.
okay. So how will you proceed this case?
Sir, I would like to proceed with a few investigations.
Okay.
Start with a routine urine culture examination and an ultrasound of the
Only routine culture.
routine routine examination and culture, routine microbiological and culture examination of the urine.
This will be a routine analysis and
And
urine analysis and
Yes.
culture.
Culture and an ultrasound of the whole abdomen and pelvis.
Whether you will not looking for a renal function or a general hemoglobin.
Sir, yes, sir. I would also like to advise for blood investigations, including complete blood count, renal function at this point.
So hemoglobin is around 11.2, that's within normal, and creatinine 0.8. And you ask for a urine analysis, it shows that parcel is 3 to 4 without any features of urinary tract infection. So now you can prescribe this ultrasonography. Describe this ultrasonography.
ultrasound shows multiple anoid areas, sir, and cystic
Sumantra?
Sir, this is a static film of the ultrasound showing the right kidney, most probably from the writing that I can understand.
That's a left kidney. That's a left kidney.
Left kidney. Okay, sir. So the left kidney shows dilated calyces, dilated and blunted calyces with thinning of parenchyma and possibly loss of corticomedullary differentiation to some extent in this kidney.
Why you said it's a pelvic calyceal dilatation? Why is not a cystic dilatation of kidney?
Sir, pelvic calyceal dilatation because this has a prominent central dilatation with peripheral dilatations arranged and possibly communication between the
Possibly there is a communication is here.
communication can be seen. So possibly this is a hydronephrotic kidney with dilated calyces.
So when you look for ultrasonography, of a kidney, ureter, bladder. For a kidney, what will be the important thing you will see in ultrasonography?
Sir, pelvic dilatation is there or not?
Okay.
Calyceal dilatation,
Okay.
and sir, thinning, corticomedullary differentiation, and thinning of cortical thinning, sir. And if there is any cysts are present there, sir, and
Echogenicity needs to
echogenesis.
So this is a left-sided hydroureteronephrosis. Okay, hydronephrosis. So what will you want to know further from this ultrasonography? Any other thing?
Sir, I would like to know whether the patient has associated hydroureter or not. I would also like to know whether the bladder is distended and the bladder wall thickness, and if the proximal urethra is dilated or not.
Okay. So what about the right kidney? So you have to know about the status of the opposite kidney also.
I'm sorry, sir. Yes, opposite kidney is also.
So here is the fine. So it's a left kidney. There is the hydronephrosis with thinning of the parenchyma, upper pole, lower pole, and mid pole also. Okay. So how will you categorize this hydroureteronephrosis? Hydronephrosis.
Sir,
It's a mild, moderate, or severe like these are grade 1, grade 2, grade 3. Is there anything?
Yes, sir. According to the SFU grade of classification.
Basically, SFU full. What is the full form of SFU?
Yes, sir. Society of Fetal
Urology.
So it's antenatal and just postnatal.
Just.
But in the adult, whether we are
dilatation.
Yeah. So usually we call it mild, moderate, severe, and that is usually ultrasonography radiologist perspective. It's a subjective parameter. So now came to this patient has a left-sided hydronephrosis. So how will you proceed these cases? What next investigation will you do?
Sir, ultrasound, does it mention any hydroureteronephrosis or this
No,
is
it's only hydronephrosis.
nephrosis.
And other ureter and the bladder is absolutely normal. No other findings.
Okay, sir. Okay, sir. Sir, thinning of kidney is there, sir. So we will like to know the differential function of the kidney, sir. And
okay.
Sir, and
so for a hydronephrotic kidney, we have to know two things. What is the anatomical details? Another is the functional details.
Functional details, yes, sir.
Okay. So the functional detail, what will you want to do?
Sir, for functional detail, sir, DTPS scan to know relative function of the kidney, sir.
Okay. And why not MAG?
Sir, MAG is not available in India, sir.
Okay. So it is a renogram. Okay. You can use a DTPA or otherwise a MAG, theoretically, because MAG is not available. It's all no. But in a theoretical purpose, you have to show is a renal scintigraphy, either with a DTPA or a what nucleotide agent commonly used, radioactive agent used in these cases. Whether it's a DTPA or MAG, that are the radioactive substances.
No, sir.
What is the radioactive substances?
Technetium 99, sir.
Yeah. So what is the properties of these MAG3 or DTPA? So why we are using it as a agent for renogram? What is the properties or difference of these two?
Sir, DTPA has low, poor protein founding. So it is basically, sir, excreted from kidney, it is filtrated, sir, basically. And so it gives basically, sir, anatomical idea, and it doesn't give.
Does DTPA give any anatomical idea? Oh,
sorry, sir. It gives
So DTPA is a glomerular filtrated substance, whereas MAG3 has a, percentage of glomerular filtration plus tubular secretion as well. 50% of the MAG3 is tubular secretion. So, so for evaluation of function as well as obstruction in the younger age group, MAG3 is a more preferred agent.
And when there is also a raised creatinine, that means there is a
Yes.
defective renal function, then we can use also
Yes.
the GMS,
Yes.
MAG3. So what anatomical investigation you would want to do for this patient?
So for this patient, the ideal anatomical study would be a CT urogram.
Why?
So CT urogram would give us the benefit of visualizing the pelvic system and its anomalies. Associated with it, it will also give us the picture of the renal parenchyma. Uh, Also, any other abnormalities outside the renal tract, any extra renal obstructive pathologies can also be diagnosed by the CT urogram. And it also gives us an idea about the functional status of the kidney.
Yeah. So nowadays it is a CT urogram, but stay for the younger age group, there's a due to ionizing radiation, usually we prefer IVP.
Yes.
So describe this IVP.
So this is the this is the control and the 10-minute film of the series of films taken for IVU for intravenous pyelogram of this patient. The scout film shows uh, um, shows a normal axial skeleton, uh, the normal vertebral column, uh, pelvis, and the lower part of the rib cage, poor bowel preparation, and no definite radio opaque shadow is visible in this film. The 10-minute film shows on the right hand side uh, a normally positioned kidney with apparently normal pelvic system, and upper part of the ureter is also seen. The left side, the left kidney appears hydronephrotic with dilated calyces, and um, partial blunting of calyces is noted in this film. The ureter is not yet visualized on the left side, the 10-minute film. So this is these two films on the right hand side. We have the full full bladder film. This is the yes sir. The right side shows a normal. Right side shows excretion and residual, some small amount of residual dye in the pelvic system. The left-sided kidney shows residual collection in the pelvic system with dilated and blunted calyces, and the bladder is full. On the next image, post-void image, shows minimal residual post-void residual collection, but still there is hold up of contrast material on the in the left kidney.
So next you want to know about the functional study.
Yes.
So here is the DTP renal. So Jitendra,
Yes, sir.
how will you prepare for a patient of DTP renal?
For DTP renogram, sir, DTP, sir, we can with giving DTP, sir, we give furosemide, sir, and it can be given at the time of DTP before 15 minutes or after 15 minutes, sir. And it's
You are
it
taking
is
about,
read.
this is basically a protocol you are talking about. It's
Yes.
a minus F minus 15, F0 or plus 20. But I want to know how will you, when a patient came to you for a DTP renogram with a normal creatinine level, so how will you prepare this patient? What advice would you give to the patient for a good DTP renogram to perform?
Sir, patient should urinary bladder should be empty before we prepare patient for DTPS cancer. And because if there is residual urine in urine bladder, it can cause misinterpretation of the DTPA reading. Sir.
Okay. Anything more?
Sir,
So there is a term, is a well-tempered renogram. What is it? Sumantro?
Well-tempered renogram is, sir, that the patient should be adequately hydrated before performance of the study. Should not be in a state of dehydration, which leads to false positive results.
Okay. Anything more? So there's a 4 point you have to keep in mind. First is hydration. Second thing, the region of interest in the during DTP procedure, radionuclide activation, the region of interest is very important, because in case of hydronephrotic kidney, the large kidney, sometimes the region of interest is too high, and it gives the false impression about the actual function of the kidney. Okay. And secondly, when the patient may be associated viewer will be there, we don't know, because of in the IVP, the contrast is above. Okay. So sometimes it may hamper the drainage of the obstructed kidney. So you have to keep catheter in there. Okay. So now read out these findings of this renogram.
So this is the perfusion film of the renogram.
Okay.
The series of images in the upper part of the sheet show the gradual perfusion of the films taken at possibly every 2-3 seconds. Films taken at every 3 seconds during the perfusion period. The graph shows 3 curves: the perfusion uptake of the left and the right kidney in comparison to the aorta. This is done to cancel the background noise and compare with the perfusion of the aorta and the renal arteries. And the chart on the right side shows the perfusion details and the GFR estimations.
Okay.
So this is the excretory part of the film. It shows the right and the left kidney really curves. The right kidney, the protocol used in this film, there are 2 marks at 2 and 3.
Yeah. Here is 1 and here is 1.
No, sir, usually the protocol is the time of introduction of Lasix is usually marked on this film.
Yeah.
So it's either the second or the third. However, the left-sided kidney shows a poor excretory pattern with rising of curve, type 2 O'Reilly curve, signifying an obstructed system. And the right side shows a non-obstructed system.
Here it is. So GFR of the both kidneys almost same.
Yes, sir.
So a 7 years boy with a almost equal GFR. So now what will you do?
So the patient is having recurrent symptoms and recurrent bouts of urinary tract infection due to possibly arising out of this obstructed urinary system. So in spite of the GFR being equal on both sides, an obstructed system with symptoms, I would counsel the patient to proceed with therapeutic interventions.
Okay. What therapeutic intervention will you prefer?
Sir, I will counsel the patient for operation. I will plan the operation of for doing an RGP followed by pyeloplasty on the left side.
Okay. Why RGP?
The RGP done preoperatively would RGP done preoperatively would give us an estimation whether there is any stricture segment or not in the upper urinary tract. Also, it will give us an idea about the length of the stricture segment and
Ureteric details, sir. If any further distal ureteric
and also any other.
picture of
Uday sir, do you comment on that? Whether the RGP is required or not at all? Hello?
Hello.
Huh, sir?
One thing, I do not do the RGP, but I do cystoscopy and before operation of pyeloplasty,
Yeah.
and put guide wire to delineate ureter, pelvis easily. Otherwise, I think I have never done RGP, particularly in the children. It is almost certain that the obstruction is at the level of junction, not it is extended or something long segment or something like that, which that occurs in case of adult patients.
Yes, sir.
But if it is written in the protocol in Campbell, then you have to utter in examination.
Now, basically, there is a controversy nowadays that if the CT scan is there, CT urography is there, if so no stone or detailing along with the DTP renogram, you can omit the RGP there.
Even we do not do the CT Euro CT, that is the contrast CT.
Yeah.
In case of huge obstruction suspected in case of children.
Yes, sir. Yes, sir. So you want to go for a pyeloplasty, RGP pyeloplasty. Okay. So what is your approach? Will be your approach for a pyeloplasty?
So I would prefer a laparoscopic pyeloplasty, transperitoneal laparoscopic pyeloplasty in this patient.
Okay. What about the endoscopic management of PUJ obstruction?
Sir, endoscopic managements, antegrade or retrograde incisions on the
endopylotomy, sir. Results of endopylotomy are not up to the marks, and there are chances, there are recurrences, sir. And now these, sir, gold standard is, sir, pyeloplasty, sir. So I would like to go for single step management, not to expose patients for multiple surgical interventions, sir. So I will prefer, sir, pyeloplasty, sir, whether lab or open.
So here is the pathogenesis. You have to wrote theory, but came to the important thing.
So what is the difference between antenatally diagnosed hydronephrosis and postnatally developed hydronephrosis? Is there any difference in the kidney structure?
Sir, in antenatal hydronephrosis, sir, there are multiple grading of the hydronephrosis, sir. 40 to 80% there is transient hydronephrosis, sir, which in most of the cases, sir, it is resolved after birth, sir. After birth, after 5 to 6 months, it resolves, sir. And sir, if there is any antenatal hydronephrosis, and sir, if antenatal hydronephrosis in second trimester, or it is divided in second or third trimester, sir. If there is an antenatal hydronephrosis in second trimester and it is mild hydronephrosis, sir, then patient will require one further scan at 32 weeks, sir. And if there is moderate to severe hydronephrosis, sir, then yes, we will require to do every 4 weeks, sir, ultrasound scan. And sir, sir, if after birth, sir, we will keep monitoring the patient, sir, and if first ultrasound scan will be done in if there is a severe bilateral hydroureteronephrosis and bladder dilatations, and then yes, we will do first ultrasound within 24 to 48 hours. But if there is no any bladder thickened bladder wall, or if there is only unilateral mild to moderate hydronephrosis, sir, then we will do ultrasound after 48 after 2 days, within 2 to 7 days, sir. If sir, after if UTD unit dilatation system classification, we will see, sir, if it is in A1 grade, then sir we will P1 grade, sir, then we will do further one ultrasound at the interval of 3 to 6 months, sir. And if there is, sir, moderate to severe hydronephrosis, sir, then we will keep following the patient further, sir. And if there is any deterioration of the renal function, and if there is any in further, then, sir, we will proceed for further investigations, sir.
No, basically, I need to ask you whether there is any microscopically kidney parenchymal changes for a antenatal hydronephrosis kidney or a kidney which develop hydronephrosis later on. Sumantra?
Sir, there is the chance of finding renal dysplasia associated with antenatal hydronephrotic kidneys. High-grade hydronephrosis with deterioration of renal function in the antenatal age group is associated with finding of microcysts or cystic degeneration.
So basically, the important thing is here, when there is the upper tract dilatation in the antenatal period, it may be associated with dysplastic kidney. So if you treated the primary pathology also, but there is always chance of end-stage renal disease for this kidney, for this patient, there is every chance. So when you count specifically for the bilateral hydronephrosis, so when you treat the patient, counsel the patient and mother, basically parent, that he may need a prolonged follow-up. Okay. So now came to the patient mother. Nowadays, mostly this hydronephrosis diagnosed in utero. Okay. So a mother presented to you with his 3-month-old child with ultrasonography. That patient had a right-sided hydronephrosis, which was also present his antenatal checkup. Now, how will you classify, staging the grade this hydronephrosis? What are the different grading systems?
Sir, there are three antenatal grading system for hydronephrosis. First is anterior posterior renal pelvic diameter, sir. Yes, sir. This is an objective classification system, sir, and most commonly used, sir. And second is, sir, Society of Fetal Urology classification, and this have 5 classes, sir, and this is subjective subjective classification, sir. It is based on, sir, basically diameter of the pelvis and calyceal system, sir, and it doesn't take ureter bladder in
abnormality.
And with pelvic dilatation, it also takes parenchymal thickness in account for classification. And third is, sir, urinary tract dilatation classification system, sir. This is 6-point based classification system, which is objective and subjective both components, sir. And it is basically combined form of, sir, anterior posterior.
What are the 6 points? These, sir?
Sir, yes, sir. So 6.4, this is, sir, first point is anterior posterior diameter, sir. Second, sir, is calyceal or calyceal dilatation present or not, sir. And third is, sir, renal parenchymal thickness, and urinary points are taken in urinary tract dilatation classification, sir.
So it is anterior posterior diameter, calyceal dilatation is there or not. Third is parenchymal thickness. Fourth is parenchymal quality is also, whether the abnormal parenchyma is there or not. Third is bladder. Fifth is bladder.
Fourth.
Sixth is ureter. And
Ureter, yes.
whether it is associated with oligohydramnios or not.
Only-
That is very important. Okay.
Yes.
So these patients are usually classified. This is a grading system. Now, how will you risk stratify this patient?
Sorry, sir.
How will you risk stratify this patient?
Yes, sir. Sir, ultimately, sir, there are two criteria, sir. First is mild, if there is anterior posterior diameter is in second trimester, sir, if diameter is 4 to 7 mm, and or in third trimester, if its diameter is within 7 to 10 mm, sir, then it is categorized mild. And if there is no any other abnormality, and if pelvic one more thing, sir, if it is associated with only central pelvic dilatation, then it is categorized as low risk, sir, first A1. And in this, sir, we will follow up after one more scan after at 32 weeks, sir. And A2 and A3, sir, that is high risk, sir. For that, rest of all the abnormalities comes in this criteria. And even if a single other abnormality is present, then it is categorized in A2 and A3, sir. And for that, we follow up with every 4-week scans.
Here's the image. So we have already know about rhinogram, drainage, CT, MRI. So nowadays, there is, when you go for fetal intervention for these patients, which parameter? Whether
Sir,
you, in which group of patient you will ask for a fetal intervention?
So there is a classification system to classify patients in the antenatal period into 3 risk groups. The mild group and the moderate and severe group. 1, 2, 3, 3 groups. The classification factors are presence of hydramnios, fetal urinary biochemistry, whether it is favorable or not, whether there are presence of cysts in the kidney, microcysts in the kidney, and the grade of hydronephrosis. So depending on these parameters, the patient can be classified into grade 1, grade 2, and grade 3. Grade 2 signifies patients who have grade 2 patients are patients which have deterioration of renal function, but there is still a chance of recovery of renal function, whereas grade 3 patients do not have chance for recovery of renal function after intervention. So our intervention is targeted to category 2 patients. Category 2 patients are they have the chance of decreasing pulmonary hypoplasia in the complications of pulmonary hypoplasia, as well as regeneration of renal function. Grade 3 patients, it is only rarely indicated only for the intent of decreasing complications of pulmonary hypoplasia.
So basically, the fetal intervention will be your this in advance, either short note or a 10-number question. So you have to what are the fetal intervention usually done?
The two commonly studied fetal interventions are vesicoamniotic shunting and a fetal cystoscopy, fetal antegrade cystoscopy.
What is the principle behind the shunt procedure?
The shunt procedure in severe oligohydramnios, there is actually the fetal urine is actually coming out of the fetus and producing the amniotic fluid, which in cases of obstruction, this normal pattern is not happening. So shunting procedure rejuvenates this cycle to produce amniotic fluid, and this amniotic fluid then helps in two ways. One is filling of the lung to produce normal development of the lung and prevent pulmonary hypoplasia, and plus adequate amount of amniotic fluid generation so that the normal growth and development of the fetus can happen, and there are no stigma of oligohydramnios.
Now, how you have done a fantastic laparoscopic pyeloplasty for this patient. How will you follow up this patient?
So there is no standardized protocol for follow-up. However, the most commonly employed one is that after removal of degestant, we perform an ultrasound scan 1 month after removal of degestant, and then follow up yearly with either ultrasonography or DTPS scan. In the event of if the patient is asymptomatic, if the patient is
Patient is asymptomatic, came to you after the 6 months with the ultrasonography that there is a hydronephrosis still persists. Asymptomatic, no pain is there. So how will you counsel your his parent?
if I have performed a post-operative ultrasound prior to that 6 month scan, then I will have to see whether the anterior posterior diameter of the pelvis is increasing or not. If the diameter is increasing, then I will suggest a renogram to see if there is a gross deterioration in renal function, split function or not, or there is persistent obstruction or not, or whether the GFR has improved or not. If there is improvement in GFR after the surgery, if there is no significant loss of split function, then I will counsel the patient that this is a normal finding, and I will proceed with follow-up. If, however, in the event of decreasing GFR or rapidly or increasing AP diameter, then I will have to proceed with some therapy, sir.
Okay, thank you. Sir, anything more to ask? Hello.
Hello.
Sir, anything more to ask?
Actually, okay, let me speak.
No. You start.
No,
Dr.
it's
Banerjee.
all right.
No. I am
Sir,
just.
sir, one
I
question,
was
sir.
calling you.
Oh, I see. Actually, I would like to
Sir, one
put
question,
in
sir.
here the role of renometry, that is USG assessment of the cortical thickness at the upper pole, lower pole, and interpolar area of the kidney, and the calyceal diameters in addition to the epidiameters. And that is a non-invasive process, and that can be carried out every 1 year, or if necessary, if we suspect that it is progressing, every 6 months to assess, because that frequently we cannot do the renogram. So that is a way of follow-up. And some of them initially improve, but after the onset of puberty, as growth spurt occurs, the junction that we create, that has got some narrowing, and that causes an inverted ink bottle effect sort of thing, which can again bring in some obstruction, which may require reintroduction of that degestant and all. So that should be kept in mind. That's it. Any more additions from Dr. Chatterjee?
One thing, what you have told, that is the USG renometry. Actually, I have learned that USG renometry from you. And one thing I just want to add, that the before removal of degestant, you just do that USG renometry to be kept as a control. And another thing, what Dr. Banerjee has told, it is very much right that this long-term follow-up is necessary. Why? But question is, how long is long enough? We don't know. One thing, that is during the puberty spurt, that the repaired that is the junction, PUJ, it is rather the component or some is the natural component, some are the desmoplastic reaction is there. That's why this junction is rather unyielding in compared to the natural PUJ. That's why when the urine output increases, that passage may not allow, it will create a relative obstruction. In that situation, what Dr. Banerjee has told, that is a digestant or something else may be necessary.
Sir, I would like to ask something, sir. There is actually no definite guideline as to when we start re-intervention in a suspected case of failure. So in questions, in exams, this question is frequently asked. How should we say, sir, that at what point we should think of re-intervention in this patient?
Normally, the standard practice is to follow it up for 2-3 years after surgery. And if everything is going fine, then people usually abandon these patient follow-ups. But those who stick to it and follow it up diligently up to the growth part at puberty, they find out these things. These are not yet standardized, I must admit, but these are certain findings which help.
Yes.
So
these are the facts. These are coming from our experience, but still it is not mentioned or stressed on the textbook.
Sir, is there any role of RGP after if patient is having persistent hydronephrosis? Is there any protocol of doing RGP or something after 6 months?
Actually, RGP, there is no parameter. What picture of RGP will tell you that this is the obstruction, this is the partial obstruction, this is the full-blown obstruction. There is no parameter. It is just a subjective matter, not the objective investigation. That's why I don't think it will be helpful.
Okay.
Where from this background noise is coming, please stop it. So Atanu, this case is over.
Hello.
Dr. Atanu?
Yes, sir.
This case is over.
Yes, sir. Next case.
Next case will present.
Dr. Anand Biani, Ajit Kumar Gupta, and Dr. Anand Biani.
Yes, sir.
Hello. Morning. Morning. Ajit is there. Where is the Anand Biani?
Yes, sir.
Anand? Yeah.
Yes, sir.
So, the 7-year male presented with the poor flow of urine since birth, inability to void urine with lower abdominal distension for few days. So, what is your further history will you take from this patient?
Hello.
Anand?
Hello.
Yeah.
So can you hear me?
Yeah.
So it's a 7-year-old boy who is presenting with a poor flow of urine since birth. And there is also an inability to void urine since lower abdominal distension since last 15 days. So I would further inquire whether this what was the initial history at the time of birth? How was the child, and thereafter since then we have to quantify how was the urine going on, whether it is interrupted in a poor flow since birth or it is a recent history, and there is any associated urinary tract infection which is present in this, any history of associated fever, any history of associated children rigor which is there or not, and further history, any further history of any spinal deformity, that is spinal surgeries, or any lump that is present at back. All these things are important, sir, for this question.
History. So history of interrupted and poor flow for urine since birth, sudden onset of retention 15 days back associated with lower abdominal swelling, occasional dribbling of urine, intermittent fever of high grade with chill and rigor. Say, no history of spinal surgery, lump back, abdominal surgery, no trauma, no history of major medical illness. So now, what will you do?
So the first differential that comes in my mind is case of posterior urethral valve.
No, you have just, there's a history is there. You have not examined the patient yet.
So I'll thereafter go for the further examination of the
yes from this
further examination of this patient with the general survey along with the abdominal examination.
Okay, so from the history, which is the acute crisis for these children?
So I can't hear you, sir. Hello.
What is the acute crisis of this patient now?
So at this moment, sir, there are two things. One is that there is an abdominal swelling, which most probably is that there is a urinary retention that the patient is having. And the second thing is presence of fever with chills and rigor. So there will be an associated UTI with it.
Okay. So on examination, you have find this.
Yes, sir.
Okay. No. Now, what is your impression now?
Sir, this seems to be a case of
no, just impression from this examination.
Sir, impression means the patient is having a bladder that is palpable up to the umbilicus.
Okay, so it's a palpable acute retention with urinary tract obstruction.
Yes, sir. Okay. It's a lower urinary tract obstruction, sir. Basically, secondary to various causes.
Okay. So now, what will we do next?
Sir, I will further investigate this this child, and that is with blood examinations, urine examinations, and a USG. Blood examination including a hemogram along with the renal function test and serum electrolytes, a urine examination, as well as USG USG of the KUB region.
Anything more?
So further.
So presented to you with history of acute urinary retention and history of fever. So will you wait for a ultrasonography to do anything?
So the first thing that I will do is I will catheterize this patient and decompress the bladder.
Before catheterization, patient had a history of fever.
So I'll start with antibiotics.
So antibiotics, catheterization in aseptic conditions, send the blood, and then
we'll further confirm my diagnosis.
Okay. So he went for a ultrasonography. Okay. So it's a bilateral hydroureteronephrosis with distended bladder with a post void around more than 400. So now what will you do?
So from the picture, we can see that there is presence of bilateral hydroureteronephrosis. There is also a distended urinary bladder, and also there is presence of a thickness of the bladder wall. All these features are pointing towards a lower urinary tract obstruction, most probably following bladder outlet obstruction following either a posterior urethral valve, or it is going to be a urethral obstruction, urethral stricture, or it is a simple meatal stenosis. So I have to further confirm my diagnosis with the help of with the help of a VCUG, a micturating cystourethrogram.
So a patient with a history of fever, would you advise VCUG?
I will first of all stabilize this patient, sir. So for the stabilization, I will actually admit this patient. If the patient is having fever, I'll start with the antibiotics. I'll send blood investigations, and if there is deranged creatinine, or there is acidosis, or there is electrolyte imbalance, I have to first correct that. So after the proper stabilization of this patient only, I will be further investigating the patient.
Yes, that's the important. So patient presented with a history of fever along with retention. So
Yes, sir.
give the antibiotics, put a catheter, relieve the symptom of the patient first, then investigate further.
Yes, sir.
Okay. So you have put a catheter, patient get relief, fever subsided. Now, what
Yes.
investigation do you want to do?
Sir, I will go for a micturating cystourethrogram for this patient, sir.
Now, patient had a catheter itself. So now, does it change your diagnosis?
Such catheter, if the catheter is going, I will first of all, the chances of stricture, the chances of meatal stenosis, all these things are gone, and still I will put posterior urethral valve as my differentials, because in that situation there is a valve mechanism where the catheter can easily go, but the patient is unable to void.
Yes. So now we want to do another investigation. What is it?
So I would actually go for a micturating cystourethrogram for confirming my diagnosis, sir.
Ajit, describe this. Describe this image.
Yes, sir. In left hand side, in the first film, there this is first film of full bladder with large capacity bladder, and there is dilatation of posterior urethra with no passage of contrast in anterior urethra, and
there is small opacification near the anterior.
yes, sir. Yes, sir. In the lowermost on left side, there is passage of contrast, which is very thin, and on left side, there is a reflux of contrast in ureter. There is on right side, there is no reflux. Yes, sir. So this is a case of most probably this is a case of posterior urethral valve with left-sided psychoureteric reflux.
Okay. So what is this? There is a dilatation, there is a narrowing, yes, but what is this near the bladder neck? Can you comment on this? Anand?
Sir, this is sir, a high
hypertrophy.
Yes, that is a bladder neck hypertrophy. That is
yes, it's a bladder neck hypertrophy. So your diagnosis is posterior urethral valve. So what is the usual age of presentation of posterior urethral valve? Is it the common that a patient with 7-year age presented with posterior urethral valve?
So normally the posterior urethral valve will be presenting at a just in the there are varied presentations, sir. It depends upon the antenatal beginning of this pathology. So it may be a newborn period, it may be within the toddler age group, or it may go into sometimes at this 7-year age.
It's the most common age.
Most common is the newborn, sir.
Yeah. So the patient with when you suspected a patient or came to you around a 3 month or 4 month age with because they have not developed a urinary uh, pattern of the voiding. So
Yes,
what will
sir.
you when you will suspect that it may be a case of posterolateral valve?
Sir, the a 3 or 4 month child will normally have a failure to thrive with presence of poor feeding, with presence of a decrease in the muscle tone, with sometimes presence of pallor associated with certain voiding symptoms that will be thinning of the urinary stream, which is going along with difficulty in micturations, and thereafter presence of uh, so
Okay.
these will be the most important symptoms.
Most of these patients nowadays, due to the antenatal ultrasonography around 20 weeks, they
Yes, sir.
presented with features. The patient will give, the mother will give the history of oligohydramnions. There may be a features of ultrasonography, antenatal ultrasonography, which will show you the bilateral ureteronephrosis.
Yes, sir.
Okay, and along with that, there will be a failure to thrive this patient. So
Yes, sir.
you have to high suspicious for the posterior valve for this patient. Okay. So, the posterior valve, what is the most common cause of mortality in this group of patients?
Sir, it is the pulmonary hypoplasia, sir.
So, what is the basic pathophysiological changes in case of posterior valve? What are the basic pathophysiological changes? What are the organs that are involved? And
Sir, the most important pathology is basically the posterior valve leading to bladder changes, which will be bladder wall thickening. Along with there will be presence of bladder wall trabeculations and saculations with elevated bladder neck and thickening of the with elevated bladder neck and also dilatation of the posterior valve. Along with that, there will be upper tract changes as well, which will be including the hydroureteronephrosis, and that will be sometimes be associated as a secondary or a concurrent phenomena with the renal dysplastic changes.
okay. A patient, you have done a posterior valve ablation at the age of 4 months, and it was a good posterior valve ablation. Patient had no bladder pathology after that, but at the age of 30 or 35 years, patient developed end-stage renal disease. How will you explain this?
Sir, a posterior urethral valve is a situation wherein we are found to be relieving the lower urinary tract obstruction, but still there is chances of persistent VUR, or there is associated renal dysplasia.
Patient lower
That
tract was
associated renal.
patient
So
lower
most
tract
important,
was
sir.
absolutely normal after your valve ablation. The lower tract
Yes,
was
sir.
normal. In spite
Sir,
of that,
there is associated renal dysplasia, sir, which is taking place, and that is actually a concurrent along with this lower urinary tract obstruction. This is the most important reason which will lead to the ESRD in a patient even after a successful posterior valve ablation, sir.
so you the patient mother and father parents about this thing. Then you need a prolonged follow-up this group of
Yes.
okay. So what will you do this patient?
What are the in utero findings on sonography that will suggest that patient where the baby will be having a posterior valve, and why that pulmonary atresia is the leading cause of death? Why that occurs?
The most important thing that we will be finding is presence of the bilateral antenatal USG will be presenting with bilateral hydroureteronephrosis. Along with that, there will be a dilated bladder with associated dilated posterior urethra. That is something giving rise to a keyhole sign. And there is most importantly a presence of oligohydroamnios, sir.
Yes.
That oligohydroamnios is the main reason which will lead to the pulmonary hypoplasia in these patients, and ultimately the patient's lung maturation will not take place.
So what is the first step for a posterior valve? A patient with a posterior valve, what will be the first step? You have seen the patient in the OPD presented to with all these features. Okay, patient. Now what will you do first? First thing.
The first thing I'll do is to decompress the bladder, sir.
Yes, always keep it in mind. Okay.
Decompress the bladder.
Decompress the bladder first. Now,
Yes, sir.
how will you prepare this patient for further procedure?
Sir, after the decompression of bladder has been done, sir, we will be further stabilizing this patients, because many a times they have they present if the patient is stable enough, then we may go for certain investigations. But if the patient is having certain electrolyte imbalance or features of urinary tract infections, or the patient may have other symptoms of acidosis, then we have to admit the patient. We have to give patients proper antibiotics, IV fluids, electrolyte imbalance correction. And after the patient has become stabilized, we will be doing a USG and a creatinine for this patient, sir.
Okay.
After the so if the patient is showing that the USG is having features which is suggestive of posterior urethral valve, as well as the creatinine will give us certain idea about the renal function of this patient or the child, we will be further investigating this patient with a VCUG to confirm our diagnosis. And we will be thereafter, after stabilizing, plan the patient for surgery, sir.
Okay. So how will you do a VCUG in a 9-month-old child who have not developed the voiding pattern yet? Not uncommon.
Sir, normally that is done under sedation, sir. We will be putting an we will be putting an infant feeding tube inside, and after that we will be putting a diluted contrast which is inside the bladder. And thereafter after taking out the that is because of the primitive reflexes that the child has, the child will void spontaneously, and we can take the dynamic images at that time, sir.
Yes. Sir, Uday sir. Hello.
Hello.
Sir, anything more about the MCU in children?
One thing, I think you have asked about the reflux.
Yes, sir.
Nature of the reflux, whether it is a purely refluxing or obstructing variety. That may be, we may gain some information from that. Another thing, the renal dysplasia, I think the question will be very much difficult. That is the dysplasia, congenital dysplasia, is it progressive? Is there any new information from the book? I don't know. I don't know the answer.
Okay, they say they give the two reasons. One is the gallbladder syndrome that lead to the end-stage renal disease, and another is the persistent dysplasia that may lead to the renal hypertension and further renal damage.
From the hypertension?
Yeah.
Just like the glomerulonephritis?
Just like the glomerulonephritis.
That means it is progressive?
Yes.
Dysplasia or sorry. Okay. Sorry, sir. There is some. Hello?
Yes, sir.
You proceed.
So, you have done a cystoscopy at type 1 posterior urethral valve. So, what are the type of the posterior urethral valve?
So the types of posterior urethral valve was classified by Young, and that is divided as type 1, 2, and 3 respectively. The type 1 is the most common, which is 95%, in which the valves are starting at the level of the verumontanum, and then they are going along the anterior urethral wall, and thereafter they are just just at the level of bulbomembranous junction. They are dividing to two fork-like processes. That is the type 1, sir. The type 2 actually is no more counted as valves, because they are actually a hypertrophy that is taking place from the superficial muscles of the trigone as well as the posterior urethral valve, and that is basically starting from the verumontanum going proximally towards the bladder neck. The type 3 is the variety which is seen in 5% situations when there is a transverse membrane or an annular ring which is present, which is having a central hole that is there is a presence of aperture which is present in the center of this membrane.
So now, what operation will you do for this patient?
Sir, the most common operation that we do here is the valve ablation that is done endoscopically, and that is, so this is the valve ablation, sir. I will do.
So whether it's a valve ablation or an incision?
Sir, it is, so it's not an excision, but can be an incision, sir. We have to not go aggressively. We have to just incise the valves and thereafter leave it to involute.
Okay. So what is the site of incision?
Sir?
When, where you give the incision?
So the incision is normally given at 5 and 7 o'clock positions, but some surgeons also prefer to give it at 12 o'clock position as well, sir.
Okay. So when you will remove the catheter?
So normally the catheter is removed within 1 to 2 days, sir.
Udai sir, what is your practice? Hello.
Hello.
Yes, sir. What is your practice for?
We used to remove catheter within 38 hours. It may be 24 hours also.
Okay. Okay. So whether uroflowmetry is needed at all in this age group after valve ablation?
No,
sir, after valve ablation, uroflowmetry is not normally required, particularly because the presentation is taking place in newborns and toddlers. Only in 7 years of age, we may quantify the volume after they have gained their, after they have attained the bladder cycle and they have gained continence, but it is not always required, sir.
Yes. Uroflowmetry, yes. Uroflowmetry is necessary, particularly those who can void on command.
To void, yes.
On command, not in the neonates or the small infant. Yes. It is a good investigation, and you can gain plenty of information. That is the Qmax. Here he has mentioned it is the 14. 14 means yes, almost in the 7 years boy, it is the almost normal. Normal. Another thing, it is a this Qmax. We should not be satisfied with this type of Qmax, as the patient with the valve, who is suffering from valve, has got thick bladder muscle. So the Qmax may be high, even without cutting the valve. That is one time is misleading, but the nature of the curve, whether it is a smooth or vibrating curve means there is some obstruction still present. And further you may, okay, I will tell. Carry on.
Okay, sir.
Yes, sir.
So these are all theoretical purpose. I now go these. So what is the valve bladder syndrome, Ajit? Ajit. Hello. Ajit, can you hear me? Anand, what is valve bladder syndrome?
So valve bladder syndrome is the situation when there is a presence of intrinsic defect of bladder, which leads to the deterioration of the renal function. That is even after a successful PUV, even after a successful surgery done for a posterior valve, sir.
What is the pathophysiology underlying this?
So the pathophysiology, sir, the most important components that are there is basically the presence of a poorly compliant bladder. Then there is presence of a polyuria, as well as the presence of a high volume of the high residual volumes. These are the three things which are there, which will ultimately lead to a vicious cycle formation, wherein the patient, even after having a successful surgery, will have further progression of the renal, the further progression of the hydronephrosis as well as deterioration of the renal function, sir.
That is the findings we can find, but the pathophysiology, why this happen?
Sir, it is because the
when there is a valve bladder, when there is a prostourethral valve, what
yes, sir.
Changes happen in the bladder in the microscopic level?
Sir, there is a microscopic level, sir. There is basically the increase in the collagen depositions along with decrease in the smooth muscle that is taking place.
Bladder
Sir.
wall
So
thickening
ultimately, they will have a myogenic failure that is taking place. Sir.
Okay. So initially there will be the detrusor hyperplexia along with the decreased compliance. Later on, it will be the decompensated bladder with high volume.
Decompensated bladder.
Okay. So what will be your urodynamics finding for this patient of gallbladder syndrome?
Sir, patient with a gallbladder syndrome, it actually depends upon what age of, sir, normally they will have presence of detrusor hyperreflexia with a poorly compliant or a low capacity bladder with presence of poor sensation, sir.
Yeah, well, initial days there is a hyperreflexia along the this compliant. But
Yes, sir.
later
And
on,
later days there will be
a...
myogenic failure leading to poor sensation. Yes.
Okay. So how will we manage this gallbladder patient?
So the gallbladder syndrome patients should be initially managed with the bladder training, sir. That bladder training can be either in the form of a timed voiding or it is a double voiding. Okay. And that sometimes has to be added upon with alpha blockers to relax the bladder necks. Okay. Suppose that is also not working, then we may add clean intermittent catheterization to it, sir.
Okay. So initial days when there's a detrusor hyperreflexia, poorly compliance bladder, can we do anything?
So we can add on anticholinergics like oxybutynine. Yes. In case of children's, that is helping.
So initial days when there is a detrusor hyperreflexia, we can use anticholinergic, but later on when there is a bladder decompression, we will ask the patient for the double void. And not only CIC, is there anything you have to do at night?
So there is something called as overnight bladder drainage, which is done with a catheterization, sir. Actually, it is breaking the bladder cycle and helps us for an extended period of bladder decompression, sir.
So, Uday sir, hello. Sir, what is the advantage of drainage at night, this continuous night drainage?
That is the theoretical proposal is good, but practically it is very difficult. Sensate urethra will not allow regular nighttime drainage. That is a problem. Okay. And we have not dealt with gallbladder syndrome. Not a single case I have dealt, because the prevention of gallbladder syndrome, there is another chapter. I'm not going to discuss that. Okay. That's why it is I am not experienced with that. Okay. Only theory.
Okay. Sir, anything more to ask about posterior urethral valve problem?
Am I to speak or Dr. Banerjee? I think Dr. Banerjee will clear.
Yes, yes, sir.
He will do some. He will say something about. Dr. Banerjee, can you hear me? Hello, Dr. Banerjee. Dr. Sugata Banerjee. Okay. Otherwise, I am summing up. Yes, one thing, that is the posterior urethral valve. The valve is obstructing the posterior urethra, and the consequences or sequels are on the bladder. Bladder is a scapegoat. How? There is the high resistance in the posterior urethra, so the bladder is pumping with the high pressure. So there is the hypertrophy in the bladder muscle. Not only in the bladder, also in bladder, there is hypertrophy in the bladder neck. And this again obstructing the system. That means initially the obstruction was in the posterior valve. Afterwards, the handover of this obstruction is shifted towards the bladder neck. At the same time, due to the thickening of the detrusor, there is obstruction in the VUJ. It is causing the VUJ obstruction. These portions are neglected, rather it is not that much focused. That's why ultimately patient may land up in Initially, it is a compensated bladder to overcome the outlet obstruction. Ultimately, it gets fatigued and results in decompensated bladder, myogenic failure, and the valve bladder syndrome. Okay.
Yes, sir.
You, Dr. Banerjee, can you hear me? No, I think some problem is there. Okay, you continue.
This was the two cases for 2 days. One is PUJ obstruction and another is a posterior urethral valve. So now we will proceed to the video presentation.
Thank you, sir.
Hello, Nirmallo. Hello. Nirmallo.
Hello, তুমি কি জানতে চাও বলো?
Sir, now it will be a video for open pyeloplasty.
কটা কেস হলো?
Today is the 2 case.
Nilanjan, I'll be doing that.
Okay.
Yeah. Hello.
Yeah, Dr. Arshad here.
Yes,
I'll be
yeah.
doing that.
Yes.
Can I start sharing the screen?
Yes.
Just give me a second. Am I visible? Are my slides visible? Hello?
Yes,
Hello?
sir. Slide is
Visible.
Yeah.
Morning, I'm Dr. Arshad from RIMS Ranchi, and I'd be talking about the open surgeries for UPGO. Indications of surgery, as has already been discussed, they're increasing AP diameter on ultrasound, or decreasing renal function, a breakthrough UTI on in a patients who are on antibiotic prophylaxis, symptoms of pain, hematuria, failure to thrive, hypertension, and development of ipsilateral calculi. So there are various types of open pyeloplasty. One of the most common one is Andersonine dismembered pyeloplasty. Second is Foley's VY pyeloplasty. Third is a Scardino Prince vertical flap pyeloplasty. Fourth is Culp deviated spiral flap pyeloplasty. Fifth is Davis intubated ureterotomy. Then there is ureterocholicostomy and salvage procedures. Now, Andersonine pyeloplasty is the gold standard treatment modality for treatment of UPGO, as it permits transpositions of crossing vessels when the crossing vessels are present, and it permits reduction of the redundant pelvis. Foley's YV-plasty is another type of open pyeloplasty which is done where there is a high ureteral insertion with associated upper ureteral strictures or stenosis, in which a Y incision is done on the pelvis on the medial side, and then it is converted into V shape. Scardino Prince is another pyeloplasty which takes care of upper ureteric stenosis or strictures, which are long segments, where a vertical flap is designed on the pelvis, where the pelvis is relatively large and box-shaped, and a medial-based long anterior flap is designed. It is turned down medially and sutured to the spatulated urethra. Culp deviated is similar to the Scardino Prince, except that the flaps are longer, and it can take a spiral on the pelvis, and then it is brought down to bridge the gap of the upper ureteric strictures or stenosis. Davis intubated ureterotomy is another type of pyeloplasty in which long segments of upper ureteric strictures can be tackled, and this can be combined with flap procedures like Culp deviated or Scardino Prince, so as to keep a minimum length of ureter which is allowed to heal by secondary intention. Ureterocholicostomy can be done as a primary procedure, especially when the intrarenal pelvis is present, or it can also be done as a primary procedures in horseshoe kidney and in salvage procedures when the pyeloplasty has failed and upper ureteric stricture stenosis is present. It basically entails division of the lower pole kidney and anastomosis of the ureter to the lower pole calyces. Procedures are ileoureteral replacements and autotransplantation with body flap pylovesicostomy. These are rarely needed, but sometimes they can be of use if the pelvis is very large and it can be anastomosed directly to the bladder. Surgical, there are basically three surgical approaches. Either it can be done by a flank approach or anterior subcostal approach or a dorsal lumbotomy approach. For a open surgery, generally a retroperitoneal approach is preferred. For a laparoscopy, a transperitoneal approach is more preferred over retroperitoneal approach because of the ease. There has been various studies to delineate which approach is better, but none of the studies have proven conclusively the benefit of one over the others. So in a general, when a laparoscopy or robotic surgery is done, a transperitoneal approach is preferred. But for an open surgery, retroperitoneal approach is preferred. Preoperative RGP is usually done, especially when endoscopic or laparoscopic procedure is contemplated. Though it is also done before the open surgeries, mainly in the cases where the ureter is non-delineated. The lower part of the ureter is not clear on the IVP. In those circumstances, preoperative RGP is essentially done to rule out the ureteric strictures at various levels. Coming on to the surgical part, this is one representative video which shows open pyeloplasty in a child by a flank approach. An incision is done from the tip of the 12th rib to the lateral bottom of the rectus. Incision is deepened to the skin and subcutaneous tissue. And after that, muscle fibers are split in their direction. Internal oblique, external oblique, internal oblique, and transversus abdominis muscles are split. Transversalis fascia is divided. Peritoneum is pushed medially, and then the gerotas fascia is incised. Once the renal pelvis is exposed, ureter is identified and it is looped on a vessel loop. It is important to maintain the orientation of the pelvis and ureter, and for that purpose, stitches are taken both on the pelvis and on the ureter to correctly orient our ureter and pelvis. Once the anchoring or orienting sutures are placed, then dismemberment can be done. After the dismemberment, is done, then the spatulation of the ureter is done. Ureter is done, which is usually on the lateral side of the ureter. Excision of the redundant ureter is not done, especially to allow the surgeon to use it as a anchor for the ureteral mobility, maneuverability, and it can be excised at the end of the surgery after the anterior or posterior is done. The apical stitch from the pelvis to the apex of the spatulated ureter is important. Usually 2 to 3 interrupted sutures are taken to secure the apex. And after that, first the posterior layer and then the anterior layer is done by either interrupted or continuous sutures. it is important to keep all the knots outside so that it doesn't form a nidus for future stones. Once the posterior layer is done, then either a DJ stent or a nephrogenic stent is introduced. There has been debates where in open surgery, when pyeloplasty is done and a preoperative RGP is not done, when the attempt is done to pass a DJ stent, it gets stuck up. So various procedures have been, various methods have been described, like instilling, one of the methods is instilling methylene blue into the bladder, so that once the DJ stent passes into the ureter, into the bladder, the DJ stent confirms the position of the DJ stent is confirmed to be in the urinary bladder. It is also important to clamp the catheter before inserting a DJ stent so that DJ stent passes easily into the urinary bladder. There are suggested advantages of nephrogenic stent or PP stent, where a lower end is cut and upper end is either put through the renal parenchyma or through the pelvis, and the lower end doesn't go into the bladder. In those circumstances, it can be clamped early on and it can be removed within a week. Usually 5-0 or 6-0 monofilament or absorbable sutures can be used for anastomosis and return can be excised at the end of it. This shows a PP silence. This can be simply pulled out at the end of 1 week. Once it is in place, the entry layer can become fashioned by interrupted or continuous sutures. The practice of putting a retroperitoneal Penrose drain is arbitrary. Pediatricians, when they do a pyeloplasty, they don't favor putting a retroperitoneal drain if they put a nephrostomy or a PCN is there. But urologist would be more happy in putting a DJ stent and a retroperitoneal drain. And then abdomen is closed in layers. For post-operative analgesia, a tube can be left between the muscular layers so that post-operative can be stilled for pain control. And then muscle is approximated in layers. And then skin is sutured back by a subcutaneous stitch. It shows the plain duster catheter and retained subfascially. And finally, scarpa's fascia and skin is closed by subfascial subcuticular stitches. Right. Thank you. Are there any questions? Hello.
Arshad, you will have to ask questions to the students. You ask questions so that students can answer.
Can I share some questions?
Arshad, can you hear me?
Yeah, I can hear you, sir. I can hear you, sir. Shall I share some questions?
Yeah, that is the plan. You will have to share some questions.
Okay, right, sir.
Okay, thank you.
Just give me a minute, sir. Hello.
Yes.
Hello. Am I audible?
Yes, yes.
Hello.
Yes, you are audible.
Okay. These are some of the questions which are there. Who would like to volunteer? Some MCQ type questions. Hello, Dr. Kaushalendra, Dr. Sandeep.
Yes, sir.
Yeah, okay. So the first question is, all of the following findings on antenatal imaging should
Sir,
raise
we-
the suspicion of the postnatal valve, except
Sir, we
taken
cannot. I cannot see the.
this with uretrectosis, oligodronitis.
We cannot see the screen. We cannot see the question. We see only the computer page. Please share screen and show it. Screen
But some
he
of
has
it is
shared.
not.
File, sir. So please open the file. Only your
Please
folder is seen.
open the file. If there is any problem, next next teacher can go ahead. He will put the question at the end.
Yes, sir. That would be good. Yes, sir. That
Okay.
would be good. I think so.
Okay.
Somehow it is not happening here.
Okay.
It is showing
Okay.
here,
Okay.
but it is not going.
Okay. So who is the next speaker? No, next teacher.
I am the next teacher, sir. Sunil
Okay. 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 Chalo. Go ahead.
Dr. Shah, please stop sharing screen.
I have stopped. Is it still visible?
Yeah, yeah. You have stopped sharing screen, na, Dr. Shah?
Yeah, I have stopped.
Okay. No, you have not stopped. Yeah.
I have stopped.
Okay. So my topic is the video presentation on ureteroneocystostomy. I will first show a short PPT on ureteroneocystostomy. So, is it visible to all? Is it visible?
Yes, visible, visible.
Okay. So, as you know that ureteroneostomy can be done on laparoscopic or open method. And I will first tell about the open methods. There are actually two methods that it can be done on extravesical approach or intravesical approach. On intravesical approach, there are also two approaches. There is suprahiatal approach and infrahiatal approaches. In open method, the ureteroneostomy patient normally remains supine, and we normally give a fenestrated incision. These are transvesical approaches. First, we mobilize the ureters, putting a feeding tube, and sharp dissection was done with tenotomy scissors. And this is the most common method, polytron Leadbetter method, where we used to make a tunnel, and we make a transmural incision through the posterior bladder wall with electrocautery at the intended site of neohiatus over the tip of the right angle clamp. And we close the original hiatus with running 2-0 sutures and dissect a submucosal channel and from the neohiatus to the original hiatus sharply using tenotomy scissors and transfer the distal ureter to the tunnel. And later spatulate the distal anterior ureter sharply with tenotomy port scissors and anchor the distal posterior ureter to the neohiatus with 4-0 cubic sutures and press interpreted sutures and approximate the urothelium of the orifice to the spatulated ureter. So this is the final picture, and we close the bladder in 2 layers using 3-0 absorbed sutures. There are many modifications of this technique. There are many modifications there. One of them is spackling technique, where we do it on extravesical approach, complete extravesical approach. And this is the infrahiatal techniques, where normally in previous days, Glenn Anderson technique was used, where we make a submucosal tunnel towards the bladder neck. So it is infrahiatal towards the bladder neck. Am I audible to everyone?
Yes, you are audible, sir.
So we then close the flow of the bladder with interpreted 2-0 sutures and take care to avoid excessive compression of these sutures. So this is the final picture. You can see that there is advancement of the ureter to a neohiatus. Now there is many problems where there is short neck. We cannot make an adequate tunnel. So to overcome this, we have there is a new technique. There is another technique called Cohen's technique, where we mobilize the ureter to the opposite ureteric orifice. So we create a submucosal tunnel sharply from the hiatus to the ureter to be implanted to a point just separate to the contact of ureteric orifice and transfer the ureter across the trigone to the submucosal tunnel. It is now commonly used. We can do it unilaterally or also bilaterally. It can be used unilaterally and bilaterally. So the thing is that we have to make 2 submucosal tunnel towards the opposite ureteric orifices. This is the basic thing. And there is another technique, approximate technique, that Gil-Varnet technique called. And I'll go back to the extravesical technique. So extravesical Lesch-Gregoire technique, Lesch and Gregoire separately describe the technique in the same time. And this is the most commonly used technique, extravesical approach, where we approach the bladder extrapolaterally as per the transvesical technique described earlier. And associated ureter is facilitated by ideation of the obliterated umbilical artery, which may be ligated and divided. The ports of the ureter is just below the land part. We dissect towards the bladder hiatus and inside the rectusal muscle along the intended path of submucosal tunnel with electrocautery. And later we make a submucosal tunnel and lay the ureter in the canal and close the rectusal muscle over the ureter with 2-0 polyethylene sutures. There is another technique which is used in especially transplant surgery. There is Bailey's technique, where we make pass a tight angle clamp in the submucosal space between 2 incisions and put the ureter there. This is a Bailey's technique. So now I'll directly go to the video. These are the basic concept, and I will first show the extravesical approach only. So I'll show a video presentation of laparoscopy. You take the implantation, left implantation. Is it visible to everyone? Hello?
Yes,
Hello?
visible, visible.
Okay. So, the situation of this patient. So you know that this is a 16-year-old female. We have got left VUJ strictures and TB marker was negative, and there are CECD showed hydronephrotic left kidney with dilated tortuous left ureter with abrupt narrowing at the VUJ. There was abrupt narrowing at the VUJ, and there was hydronephrotic kidney and tortuous left ureter. So this is the port position. You can see that there are 3 ports, 2 10-meter port and 1 5-meter port. So first we have done an cystoscopy. Cystoscopy is mandatory. Before you take immunization, you have to go for cystoscopy to see the ureteric orifices, and you may have to go for RGP also. Now we are proceeding with the laparoscopic finding. Laparoscopy. We first, as I described in the PPT presentation, we have to find out the ureter. So we can use the hardwood for initial dissection or ligation. For initial peritoneal dissection, you have to make a incision of peritoneum over the intended ureteric position, and also you have to use hook, which is very very useful. With gradual dissection, as the ureter is already dilated and tortuous, it is very easy to find the ureter in this case. You can see that the ureter is already visible. Female patient, so the female patient, so you can see the ovary is there, and it is creating some problem during dissection. So gradual dissection and also the detrusor muscle over the ureter is to be dissected very carefully. Otherwise, there is a chance of loss of vascularity over the ureter. The dissection should be done in a very careful plane, just above the ureter, separating the overlying detrusor near the bladder. Now I am doing the bladder dissection. We have to make a peritoneal incision at the radius space, and gradually we have to deepen the incision to separate the bladder from the attachments. Gradually, bladder is pulled down. Bladder dissection is very important. We have to dissect the bladder so that ureter can be easily implanted to the bladder. Sometimes we cut the supravesical artery, but here it is not needed. As you see, you can see that ureter is large enough, and it easily goes to the bladder. It is a large enough ureter, so we don't have to dissect the bladder too much. Now this is very important. As the ureter is quite dilated, we have put 2 clips. It is a wide ureteric orifice, so you don't have to spatulate the ureter, and it is easily going to the bladder. So we are making a tunnel in the bladder. We are opening the bladder now. The back end of the, you can see the mucosa is sprouting now. So making a hole in the mucosa. Now we are taking the first bite at the apex. We have to make sure that there is no kinking on the ureter. Any kink in the ureter will be detrimental. We have to take the perfect mucosal bite on the bladder. Bites are easily coming. Laparoscopic suturing should be done. It is not a problem in this case. We have to first close the lateral wall or posterior wall first. I have given the continuous suture. Intermittent suturing can also be done. Now we are putting the stent through another port. So stent is passing the bladder. And now we are closing the orifice. It is mucosal or mucosal anastomosis. So now I am closing the detrusor also. The detrusor closure should not be too tight. One to two detrusor knots to be put to make a small tunnel. So this is the final picture. We have put a drain there. So this is the port position, you can see. So I am stopping the video here. Am I audible? Am I audible?
Yes, sir. Yes, sir. You are audible, sir.
So I have not shown two important steps in this video, which I will show in the next video. So I am sharing the next video, which is the case of right aortic reimplantation in another situation, another clinical situation. So this is the case of primary obstetric meganuator, where you can see grossly dilated and tortuous distal ureter. So this is a 10-year-old male with no comorbidities. And IVF and CT showed sign of right-sided meganuator with moderate hydronephrosis. On RGB, there is sign of stricture near view, and this stricture caused the meganuator. This is obstructive meganuator. So this is the CT picture and an IVF picture. So here we also made 3 ports. For suturing, there is one right-hand 10-meter port is there, and the port. First, we have done the cystoscopy and RGP, as I have told you, and you can see the cystoscopy picture. There is a stricture near view. So now we have started the surgery, and in the same thing, we have to first identify the ureter and dissect it out. So we have to make a peritoneal incision. As the ureter is dilated here, so there is not much difficulty to find the ureter. We have to gradually dissect the superficial tissue. Hook is very good instrument in this case. for gradually dissecting out the ureter from the surrounding tissue. You can see the dilated tortuous ureter as I have shown in the RGB.
Yes.
So I put the clip on the ureter and cutting the ureter now. Now you can see that ureter is very dilated, very dilated. So I am taking a ureteric margin also for biopsy. So you can see that it's a dilated ureter. So I'm going to do a ureteric tailoring. So how the tailoring is done? So I have put one feeding tube inside the ureter. I'll show the feeding tube. First I have cut the ureter. Then I put a feeding tube inside the ureter. The feeding tube is of the 8 French size. Now I am cutting the side walls of the ureter so that I can decrease the size of the caliber of the ureter. Feeding tube is inside it, as you can see. I'm now closing the tunnel of the ureter, putting the feeding tube inside. So it is almost over now. There is a new ureteric tunnel, the new ureter, because I have cut the redundant portion of the ureter. Now I am dissecting the bladder. And dissecting the bladder gradually. You can see that now I am going to take a psoas sheet, which I have not shown in the previous video. This psoas sheet is important when bladder is not easily coming down to make the anastomosis stable. So psoas sheets can bring down the bladder another 1 to 2 centimeters. Now I am opening the bladder and the rest of the procedure is same. So now I am opening the bladder after taking psoas sheet. I am opening the bladder and now I am making the anastomosis. So I am stopping the video here because my time is over, I think. So I'm ready for taking the questions. So can I ask some questions to student? Sir? Hello?
Yes, you should.
So my question to the student, who is the student here? Who is the student?
You select somebody.
Anand Biani is there? Anand Biani?
Yes, sir.
Yeah. So my question is, what is the problem in case of bilateral ureteric implantation?
Sir, in case of bilateral ureteric reimplantation, the main problem that comes across is that there may be so one side that we have done a swasage, so the other side the ureter might not be able to reach into the bladder, sir. So so the ureteral length will become shortened enough.
Do you think it is the only problem? Only that ureter will not come easily is the only problem, or there is some other problem in case of bilateral ureteric implantation?
So the
Any other student is there? I'm stopping you here. Any other student? Mukesh Jashwa? Any other student? Can you answer this question?
So in case of bilateral uterine cystostomy,
yeah,
there is a some voiding problem in post-op.
There is some
post-operative voiding symptom may occur.
Okay, what is the post-operative voiding symptom may occur? What is the symptom?
Sir, frequency or urgency might be.
Why frequency will be there? It is the frequency or it is the voiding low? There is the voiding difficulty. Is it frequency,
yes,
or is it voiding difficulty?
Difficulty, sir.
Voiding difficulty. It is not frequency. It is voiding difficulty.
Yes.
So why there will be voiding difficulty? You have done ureteric implantation. Why there is voiding difficulty? You have done nothing to done. Is done on neck or bladder outlet.
Sir, during ureter mobilization, there is a damage of some neural plexus. So during bilateral ureter mobilization, there is a damage of neural plexus.
Exactly, there may be damage of the neural plexuses when you are doing bilaterally. So damage is more, so it can cause voiding difficulty.
Yes, sir.
Okay. Another question is: suppose you have already done ureteric implantation, and there is again recurrence of in case of ureteric reflux, you have done ureteric implantation, and there is again recurrence of the reflux. What is your suspicion?
Sir, we will rule out secondary cause of secondary.
What are the secondary causes?
Secondary
what are the secondary causes?
Reflux.
Huh?
We rule out, sir, secondary cause of vesicoureteric reflux.
So what are the causes? What are the secondary causes?
Bladder outlet obstruction.
One is bladder obstruction. Another cause? Tell me another 2-3 causes.
Sir, urethral stricture.
Neurogenic bladder.
Exactly, neurogenic bladder. Neuropathic bladder, neurogenic bladder. This may you may have not ruled out it previously, so it may cause secondary reflux.
Yes.
Another question is: suppose I am doing it laparoscopic way, you are doing it open way. So, is there any difference in success rate between laparoscopic and open? Sandeep Panna, answer please. What is the difference in success rate between?
No, sir.
No.
The success rate is similar.
What is the success rate?
Success is near about 98%.
So every surgery has a 98% success rate, or there is a range? Every surgery has a 98% success rate, or there is a range?
Sir, it has been shown that all the procedures are highly successful.
So there is a range. 90 to 98%, there is a range.
Okay. Yeah.
Okay. Okay. Thank you. I finished my presentation. So, sir, Uday sir.
Yes.
So have you got any questions?
Hi. Good. One thing I just asked the student, what is modified Lichgeiger? Is it really a modified Lichgeiger? Actually, Lichgeiger procedure is non-dismembered procedure. And modified, I don't know who modified this. Actually, in the very beginning, Whitgel, he did the procedure that is the dismembered reimplantation. And this is the one thing, they may be asked about the name of the pioneer author or who advocated those things. We just, many times we use the Cohen, Lichgeiger, Ledbetter, Politano, but so we have to know the Whitgel procedure. Is it, Sunil?
Yes, sir. Definitely.
And another thing, the success of the reflux, the success of the reimplantation, how to measure? Is it only by the to eliminate the reflux, or to see whether there is any obstructive pattern is there or not after reimplantation? Sandeep, can you answer? After any procedure of reimplantation, whether we'll go for only for the study of refluxing is recurring or not, or the obstruction is relieved. That is the
Sir, ideally both has to be seen, but
yes. That is the parameter of success. Okay.
Okay.
Can I make a point, Shunirmal?
Yes, sir.
Okay. This is partly in response to Dr. Uday Chatterjee's statement. I think the students need to know this extravesical reimplantation, the Lisch-Reguer procedure, quite carefully. It is truly a minimally invasive procedure. You can do it bilaterally, and in many cases, it's a very efficient procedure. With a bit of confidence, you may not even need a stents, and the patient can be discharged in 3 to 4 days. So it is a very good procedure. And the modification which Dr. Uday was referring is that, these the Lisch-Reguer procedure actually is modified by adding a advancement suture. The terminal ureter is advanced intravesically. It's called the Zone suture, XAONTZ. If you look into Hinman's urology, so it is a very good suture. And in the discussion between open and laparoscopic, there are so many senior urologists here who present. Originally, Hardy Hendren was the master of ureteric reimplantation, as we understand. If you go into Campbell's of the 1990s, we will have a chapter written by Hardy Hendren on how to do ureteric reimplantation. He was passionate about, the way you tailored the ureter if necessary, the way you reimplanted in the posterior wall, in the middle of the posterior wall, or sort of medially in the posterior wall, with a very stable psoas hitch. These techniques seem to have fallen by the way in laparoscopic ureteric reimplantation. And, is there adequate follow-up? You were talking, Shunirmal, about the success of these procedures. Hardy Hendren, who's done, 30 years follow-up in ureteric reimplantation. So is reflux not important, or is tailoring or psoas hitch not important, or is the abbreviated psoas hitch as effective as the proper psoas hitch described by Hardy Hendren? Is anterior reimplantation as good as a posterior reimplantation? So what are the answers to these questions?
I think that time will tell only, because we are not going, we are only see the patient for 2 to 3 years maximum, because many patients lost to follow up, sir. Udayada will tell better, because Udayada has a long practice for long duration. So you can tell better what is the follow-up, exact follow-up.
One thing I have mentioned, that is the follow-up. I prefer to follow the patient whether the obstruction is occurring or not the reflux. Any operation, what you do, any reimplantation, most of the time reflux will go. But when it has gone, then you have to see whether obstruction has been created or not. That's why, in my experience, I am mainly focusing on the prevention of obstruction. That's why I have not got that type of obstruction. And one thing, just to mention, the modification by Jaun, that is also a non-dismembered reimplantation. But Whitgel is dismembered reimplantation, which is most commonly done in the transplantation and in the obstructed system. And other follow-up means, that is most of the time I used to mention, that is the follow-up should be done with the GFR, not with the creatinine. It will not show the failure, how much failure is going on. Okay, next. Dr. Sarkar?
Yes.
Anything?
No, I think I appreciate your comments, in particular that the follow-up with GFR is probably much more useful than following up with the follow-up with GFR of, or even a split GFR on a DTP arenogram is probably more useful than looking at the curves. And patient symptoms are also important.
Yes.
But only one thing, I appreciate the excellent, excellence of laparoscopic reimplantation and the benefits of the patient. But I have one simple question. Is anterior reimplantation, should we forget the reimplantation of the ureter into the posterior wall versus reimplantation into the anterior wall as is commonly performed? Do you have any answer, any of you actually? Kidney transplants are routinely placed on the anterior wall. Follow-up is good. That doesn't seem to be a problem. But in a child, would you reimplant on the anterior wall or on the posterior wall? This is what
Actually, the basic problem was supposed to be that due to distension of bladder, there may be some kinking if there is the anterior placement of. Actually, posterior trigon is a fixed part. And after implantation, due to the dissection, the area become fixed automatically. But the Schwarz hitch was developed with the same idea that we have to fix the area of reimplantation. So we have not faced that type of problem, whether it is creating some chronic problem due to the anterior reimplantation, not going to the of its original position. I think it is better to place it in the anteriorly or rather superiorly, not towards the posterior trigon. That area has got highly neurovascular network that may be damaged by this reimplantation. So it is better to go for implantation in the free area, what is done in the transplantation surgery. Any comment?
I agree with you. I think, you shouldn't go too down. And I usually, having been sort of inspired by Hendren and others, and when we learned this procedure, more inspired by implantation on a very stable posterior wall, and especially with more experience of adult work than pediatric work, but that's one. And there's also the issue of this 5:1. Should the students know this concept of how long the tunnel should be? It is written in Politano Ledbetter's original presentation that the tunnel length should be. I think this is something which is commonly asked by
Yes. That will be asked by the many examiners.
And one of the, I think Sandeep had put in a question in the chat box as to, this is a question, Uday, you should maybe answer as the most senior pediatric surgeon, is this issue of Cohen versus Politano Ledbetter or similar type of surgeries. And what are the advantages and disadvantages of doing it in adolescent, and with your experience in adult urology as well, what are the difficulties in retrograde access to the upper tract in patients with Cohen? This is something which I think adult urologists will be asked in their exams.
Actually, Cohen is rather simple operation. In one tunnel, you can put 2 ureter. That's why dissection is minimal and it is a transtrigonal. There is no damage of the posterior trigon is not damaged. And another thing, it is the common practice. It was common practice. In the meantime, when the ureteroscope came to market, then everybody told that there will be some problem for ureteroscopy afterwards. But after that, when the flexible ureteroscope came, then that objection rather became lighter. And in my experience, I have seen that is the position of the ureter after operation. When we are doing the operation, the position is almost looking laterally. But after operation, I was surprised to see that the ureteric orifice is looking towards the trigonal apex. That's why I think Cohen operation is simpler operation compared to the Politano. Who can do Politano? Okay, no problem.
Yes, I totally agree because, despite what is written in the books, it is actually often possible, quite easily possible to cannulate the Cohen ureter, Cohen reimplanted ureter, retrograde, in a retrograde fashion. Otherwise, I think the students need to know that if you've got a stone in a reimplanted ureter, that may be a very difficult problem for access. And you may be asked to use all your innovative skills to answer how you would approach it. Maybe an anti-grade approach, place a guide wire into the bladder, straighten up the ureter, then have through and through access and go up, and similar things. So that is something which an adult, which you may be asked in your MCH, general MCH exams. The other thing which I think was briefly discussed was this issue of voiding dysfunction after bilateral reimplants, and specifically if you are doing bilateral extravesical Lischpreger type of implants where the pelvic nerves may be disturbed. But there are also techniques described where you can preserve the terminal ureters, try to preserve the nerves, the inferior vesical arteries. They entered the terminal ureters posterolaterally in the depths of the pelvis, and you can try to preserve those arteries. Those people who are masters of the extravesical technique have described ways to preserve these nerves. So I think that is that is, I think, a point which is well taken. And the other thing is that students may be asked what the danger of the Politano-Ledbetter operation is. Especially where you are going through. If you remember, the ureter is pulled into the bladder again from the superior hiatus, and when you manipulate the right angle up and down, you may injure the peritoneum, which is attached to the terminal end of the ureter. So if you're a blind Politano-Ledbetter, that thing makes us a lot of, gives the average urologist a lot of worry that you are maybe going to perforate the peritoneal cavity at where you are manipulating the ureter. So maybe an intra and extravesical procedure may be helpful. Really, I've spoken enough.
Am I audible, sir?
Yes, you are audible.
Please put your question if you want.
Hello. Okay.
Yes.
Now we can proceed further. Punimal, anything?
I think our time is over, sir.
Okay.
We can wrap up the session now. If everything is discussed.
I think there are some MCQ questions. Is it to be done, or some short questions as advised by Dr. Banerjee? Dr. Banerjee advised there should be some short questions.
Most of the questions are already discussed, sir.
Actually, today I could hardly participate because all the time I was grappling with the internet connection. At the last moment, again, I could have an entry. But yes, I feel that the MCQ questions are good for the entry into the course. Once you are there, now you have to face the viva voce as well as the short questions while presenting cases and all. So those will be more pertinent and those should be practiced. Do you agree with that?
Yes, sir.
And one thing,
yes,
can you ask that sample question that may be asked by the examiner in hall? Most common question.
Yeah.
And
regarding which topic?
Reimplantation or reflux or hypospadias or anything as a whole. This is the sum
yeah,
of
those discussed earlier.
Yes.
But in the PUG obstruction, one question is commonly asked that if a fetal kidney is found to be hydronephrotic, particularly unilaterally without any hydroureter, which is confirmed in postnatal ultrasound, do all of them require surgery, and how you follow it?
In the PUV.
Yeah, PUJ.
PUJ, yes. No, yes, that question is not yet asked. That is the. Can you answer, Sandeep or Mukesh or anybody regarding this one?
So most commonly, there is transient hydronephrosis that will get resolved on its own. There are few chances that it might be related to we have to follow it up according to the grade as per UTD classification, and if there is deterioration, if they find a hydronephrosis or the function is kidney function deteriorates to less than 40%, or there is repeated infection, or there is symptoms, then we have to intervene.
Good.
So do you allow them to slip into that 40% function? Don't you catch them up beforehand?
So any sort of function, if it decreases, we have to.
Yeah. So if it remains stable, or some of them improve actually, and there you can wait and watch. But if it deteriorates on successive renometries, then you should take action. And is there any role that is experimental, of course, not freely available? Gadolinium enhanced MRI in finding out the degree of obstruction in PUJ.
Sir, MRI, gadolinium contrast MRI urography is an upcoming imaging modality to assess both the functional as well as the anatomical abnormalities associated with PUJ in a single investigation, sir. But it is not yet fully recommended in the normal course of evaluation of the patient.
Because it's not freely available.
Yes, sir.
But otherwise, it has got a tremendous potential.
Potential, sir, right.
Yeah. And I think Dr. Uday Chatterjee has already asked questions about posterior urethral valve and their subsequent management, isn't it?
Yes, I have already mentioned there is something regarding the prevention of valve bladder syndrome.
That's right.
Okay.
And a term been analyzed. What is pop-off mechanism in posterior urethral valve?
What is COPAM? Pardon?
What is pop-off mechanism in posterior urethral?
Pop-off mechanism, sir, it is considered to be a protective mechanism where the poorly functioning kidney unit develops vesicular reflux as a method of diversion of the pressure from the bladder so that the opposite better functioning kidney can be preserved. It has, however, on long-term analysis of this condition, it has shown that it does not provide any definite long-term benefit in preservation of progressive renal deterioration. However, it is still considered one of the protective mechanisms by natural protective mechanisms. Sir.
So that is a rather good as well as a diplomatic answer.
Good answer.
Okay. Anything more from any of the teachers?
Sunirmal, anything to ask?
I think everything is covered. Nothing more to ask. The basic things are covered.
Okay. What is Dr. Ranjan De's? Dr. Ranjan De?
Sir, it's an excellent discussion going on. Excellent discussion going on. And students are also answering reasonably sensibly. I think if you have the ready MCQ, the purpose of sending the MCQ, Bimalesh told me that he has prepared the MCQ. If it is there, you can show it to them. It will cover the salient features of the entire discussion today. That is how these MCQ things are prepared, so that if they know those salient points, they can answer the short questions whenever it is necessary.
Where is
Because
Vimolesh?
we have some time. If you have it ready, please show it to them. Is it ready, Sudhada?
No, actually it was bestowed on Vimolesh. I think he's off.
Oh.
That day Nilanjan told Vimolesh to
Nilanjan,
get
do you have
ready.
that? Or our bus office, do you have that MCQ question?
Sir,
Nirmalo?
yes, sir. I'm having some question. I'm just.
You please share the question.
Yes,
and
sir.
with Dr. Nilanjan Mitra or Sunirmal Chaudhary sir or Dr. Athanujana sir, so that it can be conducted in short time, 10 minutes time. Do it fast.
Yes, sir. I have 5 PPTs there, sir. Please.
Hello.
Sir, mock, sir, I don't have that MCQs work, sir. Nilanjan haven't shared me. I have.
I think.
I have only the high post PDS. Some questions.
Okay, okay. If it is not ready, then we can say it's a lovely session, and it is finished well in time. I want to hear from the students whether they got any special message from this class today, because I ask this question every day to improve our session. I don't know whether we are able to improving day by day, but anyway, I want to hear from the students if they have anything more to say regarding this class, so that this year or the next year we can take that into consideration for improvement. Anybody should volunteer from the student group. Still there are 22 students. Please come up and answer. Dr. Priyanku. Dr. Priyanku.
Dr.
I
Sandeep?
think nobody is in.
Yes.
Yeah.
Dr. Sandeep?
Yes, sir.
What's your opinion about?
I like to know what is your feedback about this class, so that we can improve our present procedure.
The class really has been excellent, and it has cleared many of our doubts, and it has they helped in the revision also.
So you want to continue the class like this only?
Yes, sir.
Thank you very much. Thank you, Professor Banerjee, and thank you, Udada, Nilanjan, Atunu, for excellent effort you people have put up to make it a very successful class for our students. Its session is meant for the students. If the students are benefited, we all will be highly happy to appreciate the efforts of the teachers and the organizers to continue this session later on in the year as a continuous session. Thank you very much. We wish to meet next weekend with a new session, which will be announced very soon in our forum. Thank you very much, sir. Thank you.
Thank you.
Good day to all.
Thank you, sir.